Trauma Therapist Podcast, episode 562. All right, welcome back to the Trauma Therapist Podcast. My name is Guy McPherson. My mission is to raise the awareness of trauma and to support and inspire new trauma therapists just starting out on the trauma-informed journey. I do that with my membership community, Trauma Therapist 2.0, my online courses and workshops, and the Trauma Therapist newsletter. If you're a therapist of any kind and you work with individuals who've been impacted by trauma, I invite you to head on over to my website at thetraumatherapistproject.com. That's thetraumatherapistproject.com. All right, let's get started. All right, Julia, you ready to do this?
I'm ready.
All right. Okay. So 5, 4, 3, 2, and 1. All right, folks, welcome back to the Trauma Therapist Podcast. Guy McPherson here. I am very excited to have as my guest today, Julia Barry. Julia, you ready to do this?
I'm ready.
All right. So Julia is a licensed marriage and family therapist, somatic experiencing practitioner, and certified EMDR practitioner in Boston. Julia's clinical practice focuses on the treatment of trauma and dissociative disorders. She has received training in psychodynamic psychotherapy with an emphasis on adult and infant attachment, as well as cognitive behavioral therapy and advanced training in somatic experiencing and EMDR. Julia remains passionate about staying up to date with the most cutting-edge modalities in the field of trauma treatment. She also enjoys being an assistant in the somatic experiencing 3-year professional training. All right, Julia. Obviously, just a little bit about you. Before we get going here, share with the listeners where you're from originally and where you are currently.
Yeah, they're very different places. I'm originally from Santa Monica, California.
Okay.
So an LA native. We're sort of like unicorns.
Uh-huh.
And now I live in Gloucester, Massachusetts, and I work in Cambridge, Massachusetts.
Nice. Why or how did you get all the way across?
Yeah, I'd done some time in New York in undergrad, but the Massachusetts stint came by way of my now husband, who has lived here for his whole life and has lived in Gloucester for many years.
Very cool. I spent some time there, and those summers are brutal.
Yes, they are, but they're also beautiful. We're starting to get that beautiful East Coast summer gardening weather.
Nice. Well, good for you. All right. So let's dive in here. Reading your bio, the topic of dissociative disorders comes up, but we'll get there. But share with our listeners how you got into this field and this specialization.
Sure. Yeah, it was an interesting route. I trained as a yoga teacher early on in my life, in my sort of late teens, early 20s, by way of some personal challenges that were going on. I ended up enrolling in a yoga teacher training one summer, and fell in love with yoga practice, and very quickly started teaching. And it was sort of on the cusp of the era of trauma-informed teacher training, meaning there weren't a lot of people teaching trauma-informed yoga. I think Judith Lassiter was maybe the only teacher in a 500-hour teacher training who ever mentioned the word trauma and talked about how to work with it. And so in my early days of teaching, I felt very secure in guiding people through a physical practice. And there were a lot of people having what I now understand to be kind of abreactive emotional experiences, really kind of big emotional, physiological releases in yoga. And I had no idea what to do with it. And I had some interest in psychology. My grandparents were psychologists. I'd had some notion that I might study. And I had this curiosity about, there must be people out there who are doing kind of body-based psychotherapy work. And I found Waking the Tiger, Peter Levine's book, and kind of never turned back. That was that. Okay.
Now, let me just interrupt for a second.
Sure.
So, it's one thing to be aware of these kind of experiences, and it's another to kind of move towards them and be interested in them and feel that you can sit there. Talk a little bit about that? How did you recognize, well, you know what, I can do this?
Well, that's a cool way to ask the question, because I think initially as a yoga teacher, my felt sense was, I don't know how to sit with this. There was this sense of whoa, there's something really big happening here. And I don't know that I have the skills or the tools to work with this. And I think my curiosity and exploration was really about learning how to do that.
Mm-hmm. Well, but you move towards that.
Right.
That's what I'm kind of getting at.
Yeah. Yeah. I wonder if there's something innate in those of us who are drawn to this work, right?
Mm-hmm.
There's some innate knowing, even if the cognitive mind says like, I don't know how to do that,
Mm-hmm.
right? That
Mm-hmm.
maybe there's some sense of ourselves or our own discovery of our own embodiment that helps
Mm-hmm.
us to feel confident in our ability
Mm-hmm.
to be with kind of large physical and emotional releases
Right.
in other people.
So you found Waking the Tiger.
Mm-hmm.
How do things unfold from there?
Well, over some period of time, I managed to get myself into graduate school, and I think in a way that was pretty unique, almost immediately enrolled in the somatic experiencing training. So I sort of had this sense of like, okay, if I'm going to do this, I want to be learning about these more embodied trauma healing modalities.
Mm-hmm.
And I got really lucky in that my first clinical placement was at a clinic that was run by a woman who was a somatic experiencing practitioner.
Well, where was this?
This was at a clinic called the Women's Clinic and Family Counseling Center in West Los Angeles.
Okay.
And the supervisor's name is Carla Becker. She's still there. She's an LMFT and an SEP. Really wonderful kind of early mentor. And I think I had a really unusual experience of being able to apply what I was learning in the training in my early clinical days.
Mm-hmm. That's so cool how that works out like that. All right. So you get in there, you're learning, you're going through the courses as somatic experiencing courses. What's it like for you as a new clinician?
I think in the same way I would answer your question about like, how did I know that I could work with it? I think there was a sense of like, oh, there's some part of my being through either my own early conditioning or my own karma that like, this is what I'm supposed to be doing.
Mm-hmm.
And so that felt comforting. And I think I had the support of people like Carla and other supervisors who were sort of encouraging that, like, oh, there's some kind of innate something here that works.
Mm-hmm.
And then there was like the practical learning of how do you actually do this?
Right.
Like how do you apply these things that you're learning theoretically in a 50-minute session with another person who's suffering?
Mm-hmm.
And that was a big learning curve.
Mm-hmm.
That was a real learning curve.
Yeah. I want to hear about that because, for many of us, and maybe you're different, probably are, but for many of us, there's you're learning all this awesome stuff. You want to get in there and you want to apply it. It's like you've got, page 222 of Peter Levine's book, and it's going to work with this particular client. I'm going to.
I would say that the biggest learning curve, particularly around the SE work, was, when you go into these professional trainings and we do these practice sessions with each other. So meaning with other students in the training who are, for the most part, clinicians or body workers who have some connection to their embodied experience from the get-go. And generally those sessions go pretty beautifully. They sort of go the way you would think that an SE session should go. And you have these great assistants who are supporting you in the process. And you get all excited, it's Tuesday and you go into the clinic and it's like, oh, I can't wait to try that. And someone's sitting in front of you and you ask a question like, so what are you noticing in your body? And they say, what are you talking about? Or what do you mean, my body? I'm telling you about the guy who cut me off in traffic. Like, why are you asking me about what I'm noticing in my body? So that real disconnect between what we might hope to be able to provide for people and where they are in the moment that they come in, which if they're having an experience of suffering, they're probably pretty disconnected from their embodied experience. There's benefit to that disconnection. So that was a real learning curve for me, I think.
So in addition to that, I mean, and aside from that, can you draw out a particular, kind of early error you made, clinical error you made, and you kind of look at that a little bit?
Yeah. I mean, the biggest clinical error that I can think of from early days has less to do with that sort of disconnect between my expectation around SE work, sort of like what SE looks like in the training versus in the reality of a clinical environment. I think it had to do more with learning about the limits of my ability to impact and enforce change in somebody else's life. I had an experience with a young woman. She was in an intimate relationship where there was domestic violence, and it was quite clear that there was real imminent threat. And I think I felt as a clinician totally helpless, but didn't know at that point how to identify that feeling in myself. And I think felt quite pulled, even if I didn't take action in this way, to get more involved in her safety than was probably clinically sound. I think I felt unclear why in domestic violence situations we had sort of less authority to assist in safety than we do in, say, suicidality or homicidality. I was really wrestling with like how much of her suffering and my own concern about her I would take home with me every day. And it was a huge learning curve. I mean, it really consumed me for the time that I was working with her. And I don't know that I ever took action in a way that was a clinical error, but I think certainly my own process and my own stance in working with her was a huge learning curve around power and how to have equanimity in those cases.
In that moment, during that time, Julia, what would you say you believed your role to be as a therapist?
Well, I think that I felt that my role was to help her stay safe. And I think in a certain regard, I was right about that. But I don't know that I necessarily knew how and what the limits of my own power were around how to keep her safe. Right. And I think naturally as a human being, when you sit in a scenario like that, we want to say, like, get out of there.
Right.
Like, get out of there. And that was sort of the inside of me was screaming in that way. But learning what to do with those feelings, I think, was another matter.
And now, with that time elapsed, what would you say your role is now?
Well,
or how would you define it?
Yeah, I mean, I think in similar situations, my role is to help the person gain some insight about, what's working and what isn't working, right? And to understand what might be motivating them, right? What their needs are, and how I can help them to understand what needs to change. And I think that helping someone stay safe is still the goal, but how to get there, I think I have a different perspective on, right? How do I sort of like tease out the parts of a person that might be motivated to stay in a situation that may be unsafe, right? And what part of them may already be feeling what I'm feeling inside, but might not be willing to acknowledge it. So I think it's more nuanced than I understood it to be.
Right. And, what does that word mean, to help, right? How does one define that? Because I think for a lot of people, when they get into this field, it's with the best intentions to help, to heal, to fix, to cure, to take away the pain.
Yeah. And I think that case, part of the reason that case jumps to mind when you talk about, an early sort of clinical failure is I think that became a defining lesson and became really important in terms of the population that I work with, right? And I am much better now at understanding both the role of power, like you said, in the helping professions, like what am I bringing to the table as a quote unquote healer who wants to heal, right? And how do those power dynamics either shape the relationship or mimic some of the trauma relationships that have existed in the past, right? And also just to understand in a much different way, to have a real sense of equanimity around like the different life paths that we're all on, right? And that it's really not my job or my responsibility to try to fix something that is not mine, right?
So, you're using that word power, which is a very charged word, I think, within this context. Talk more about that and equanimity within this context of trauma and therapy.
Yeah. And I think this has been, a big piece of learning as I've moved on in my career too, that the helpers in us, right, can show up in a way that can actually be quite terrifying, especially when there have been perpetrator dynamics in a client's life, right? And how have people who turned out to be perpetrators presented themselves initially as helpers, right? And generally those are people who are in some position of authority or power. And recognizing, in our field, that when you're sitting in a chair as a therapist, being paid in a profession that's generally well respected, that we're inherently in a position of power, whether we like it or not.
Right.
And how that power gets used, acted upon, engaged with, or hopefully, I think, handed back to the person sitting in the client's chair. And that's something I really try to do. Yeah,
I love this. So how does one, with the knowledge that this is, again, very nuanced and it's going to look different in different situations, how does one do that? How do you bring that out into the open?
Yeah. I actually think there are some SE techniques for doing this that are really helpful. And the first is actually, it's pretty unusual, but generally when somebody walks into my office, which, will happen again one day, I ask them where they want to sit, right? And maybe they want to sit in my chair, and that's okay, right? That sense of like, from the get-go, I'm not establishing a stance in this room where it's understood that I sit here and you sit there. Or I sit in the chair that looks like the therapist chair and you sit on the couch, which is where the client belongs, right? It's like, where would you like to sit? And it's sometimes very disarming for people, especially if they've been in therapy before.
Right. Is this a test?
It's like, well, I sit here and you sit there.
Right.
But I think it opens up the ability to explore safety from the get-go, which is like, once they're settled in the chair, I might ask a question like, how did you know you wanted to sit there instead of here? And usually it's something along the lines of, well, I can see the door from here. Or like, I know how to get out from here, right? It's something about the spatial awareness that gives them a perceived sense of safety. So I think that's one way. I think the SE languaging is very good for working with power, because we're encouraging a language of curiosity, right? Would it be okay to notice that, right? If there's a sensation in the body, a question like, I wonder if it would be okay to stay with that for a little while. So even in the questions, we're creating a sense of curiosity as opposed to pay attention to that.
Right. So it's very collaborative, inviting.
Yeah.
You're not directing, dictatorially in a sense.
Yeah. And hopefully their body is directing it, right? Their body is directing where we're moving, where we're going, as opposed to my bringing my own agenda to the table.
I love that. And yet it's such a balancing act, right? Because there is that inherent power dynamic, societally imposed in a sense. Oftentimes it's I think encouraged by certain therapists, of course, but yet to dissolve that and even shine a light on that and create an awareness around that. I love what you're talking about here. How did your interest in dissociation come about?
Yeah, it was kind of an accident. I think the fact that I had this early interest in trauma work, it just sort of ended up that many of the clients who were showing up, even in my early clinical days, had some level of dissociation, if not dissociative disorders, that again, I really didn't know what to do with, because I had this sort of Pollyanna perspective of like, I'm going to help people work in their bodies and it's going to be so wonderful. And then of course there are people sitting across from me who, for very good reason, are not connected to their bodies. And I was able to get some support both from supervisors and from my own therapist who worked with dissociation, and just getting more education and more learning.
And how would you define dissociation?
So dissociation it's a natural response to overwhelming experience, and it exists on a continuum, right? We all dissociate in one form or another, from the sort of like highway hypnosis of driving down the road and thinking like, oh, I don't really know how I got home, or I don't really know what I was thinking about while I was driving, to the more clinical experiences of, depersonalization, feeling like your own self isn't real, or derealization that the world isn't real, to the more sort of compartmentalized experiences of a dissociative identity disorder, for example.
When you first started out, Julia, what was it like working or experiencing the person sitting in front of you who might have been dissociating? What was that like for you?
Yeah, I mean, I think it was the way it is still, except that now I have a little bit more understanding of what's happening when it's happening. But part of what I find interesting about dissociation is how easy it is to get pulled into that vortex, because we're so connected, neurophysiologically, that dissociation has a particular effect, that when the client begins to kind of move out of their own embodied experience, it's often true that sitting across from them, I feel like, whoa, where did I go? And I think when that was happening early on, I maybe didn't know how to acknowledge that in myself. And it probably was a fuzzier and more confusing experience than it is now.
You I was just thinking as you're talking, you seem very grounded.
Hmm.
And I was thinking, sounds like from the get-go, you've been drawn to, body work, yoga, and, this recognition and a certain awareness of one's body. I didn't have that, I certainly didn't have that when I was in graduate school, and it was very different. But I really appreciate, what you're talking about, and this awareness. You're talking about it in a way that I think is really important for people to hear.
Hmm.
Um, in your bio, you talked a little bit about, or I read, it's important for you to keep up to date on things. And with the plethora of modalities out there, how would you suggest people listening to this podcast, how do you go about, okay, I'm going to invest this time and money in SC or SPI or IFS?
Yeah, it's a great question. And the truth of the matter is, like, in terms of my training, I'm not totally up to date because the modalities change so fast, and we're all only human and can only, sit in front of a computer screen at this point for so long. But I think, there are plenty of trainings that I would be interested in taking, like brain spotting and the ways that EMDR have evolved. And I have along the way picked up other, trainings like hypnosis. And I've chosen for two reasons, and I think maybe this is a helpful way to answer the question. One is either out of my own personal interest, right?
Mm,
SE was really about like my own passion, like, oh, I really want to learn how to do this. EMDR was a sort of a natural progression of, okay, there are some cases where SE is helpful to a point, but I maybe need something that has a kind of a different effect or is a different tool. And then there were things like hypnosis where it just became very clear with the population that I was working with that I really needed hypnosis training. And
mm-hmm.
that was a modality that was, indicated in the treatment guidelines for working with dissociative populations. And so I had to get myself trained. And I wasn't necessarily passionate about hypnosis in the way I was passionate about somatic experiencing work. But I think if it comes from a place of like, I have to have all of these certifications in order to feel like a good therapist, that's a perspective to check.
Mm-hmm.
For me, it was really either about, again, my own excitement about something, my own immersive experience in a modality, or, wow, I'm really missing something that I think I really need in order to help the people who are sitting with me every week.
Right. That makes a lot of sense. I think it for me, it feels easy to feel like, because there are so many modalities out there, you've got to be studying all these things. You have to know all these things, or at least some of it. But like what you're saying, number one, you can't possibly, but also it seems to me, which one is resonating with you specifically. And it might be that the person sitting in front of you, they might need something else, which
Right.
you might not have, and therefore you might have to refer out.
Yeah. And I think, it's interesting, like when I think about those three trainings, which are sort of the primary, kind of big trainings that I had to go through, I use them all in one way or another for myself.
Mm,
So they've all been personally enhancing.
right.
And I think that means something, right? That there's that sense of like, I know when I need a little bit of SE settling and I know how to do that. Or I know when I need to do a little EMDR tapping at the end of a long work day, or I know how to use some self-hypnosis for sleep or for anxiety. And they've all been really helpful ways of developing my own experience of resilience and regulation.
Right. Yeah, I really like that. How have you been dealing with this past year, and just professionally, how have you been dealing with it?
Yeah, it's been hard. And I've had, personally, I've had an easier time and an easier go of it than many people have. Right. So I can say that on the personal side, even though we've all gone through personal challenges this year, I haven't had that knocking on my door in the way that a lot of people have. And work has been tremendously hard. I think, I don't know that any of us were trained how to do this. This was not a scenario that was talked about in graduate school. And I think the combination of, just the heaviness that everybody is going through, but also so I have a mentor, and I will give him credit for this because it's his term, Dr. Richard Shevitz, and he talks about when the therapist is in the trauma with the patient. And I think that's what we've all been experiencing. So much of what I hear day in, day out on a daily basis in terms of people's anxieties and existential fears are the same fears that I'm having.
Mm-hmm.
And then how do you kind of hold that emotionally? And then I think in addition to the drain of the computer work, which is, it's just a different energy output. It's been very challenging.
Right. So let me just reintroduce you. I'm speaking with Julia Barry. And your website is juliabarrymft.com. So what's going on for you right now? I mean, are you continuing to see people online? Are you starting to see people in person?
Yeah, for now, I'm still seeing people online. Massachusetts just reopened. So we're trying to sort out at the moment how the reopening impacts clinicians in private practice.
Mm-hmm.
The guidelines are a little bit unclear. So I think we're all kind of in a little bit of a waiting period about when we're going to be able to go back to work in person. And obviously we'll do it when it's safe.
Right.
So I'm working online, seeing clients from home online. And then I'm also assisting SE trainings. Primarily, we have a Boston cohort going, which has been really fun. It's been really great to support some clinicians in Boston who are starting out on their SE journeys and providing some personal sessions to them. That's been very rewarding. And what else do I have going on at the moment? That's a lot.
It's a lot. Awesome. All right. So as we wind down here, Julia, how about a go-to book recommendation, whether trauma related or not?
Yeah. I mean, obviously, I have to talk about an SE book because I think Peter Levine's In an Unspoken Voice is a no-brainer. But I also thought of a book really inspired by your question about early clinical failure, which is a book called Bad Therapy. Master therapists share their worst failures. And it's by Jeffrey A. Kotler and others. It's a series of vignettes. Are you familiar with it, Guy?
No, but I'm familiar with Jeffrey Kotler.
Yeah. So this was a book that I think the week before I started my clinical training, my therapist told me about this book, and it was very regulating.
Awesome. All right. We'll have those up here at the show notes page at the traumatherapistpodcast.com. Well, Julia, it's been a delight having you on here. I'd love to have you back. Keep in touch with you. You are a breath of fresh air. Appreciate it.
Well, I'd be happy to come back, and it's a pleasure to talk to you. Thank you so much for having me.
All right. Stay healthy and take care.
You too.
Bye-bye.
Thanks. Bye.
Thank you so much for listening and supporting this podcast. And if you'd like to join the hundreds of other therapists who are each month keeping up to date and informed and inspired about what's going on in the world of trauma, I'd love to invite you to head on over to the Trauma Therapist newsletter. That's the traumatherapistnewsletter.com.